All right, welcome everyone to the Oregon Health Policy Board meeting. I think agenda's coming up on the screen and we will get started. I'm Kirsten Isaacson, Vice Chair, filling in for Oscar today to chair this meeting. We'll start with some housekeeping. The Zoom chat feature in today's meeting only allows meeting participants to message the host and co-host and no other meeting participants. Any questions, thoughts, comments can be sent via Zoom chat to the meeting host, co-host, or emailed to the Oregon Health Policy Board at healthpolicybord.info@dhsoha.state.or.us. And we'll put that target, you'll put that in the chat, right? So people have that email easy. Mm-hmm. Great. All materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in the meeting materials column of today's agenda, just like you can see on your screen right now. And I think it is time, we'll start with the roll call.
Great, thanks, Kristen. So Oscar Arana will be out today. So first up, Kristen Isaacson.
Present.
Ebony Clark. Okay, we'll come back. I know Jessica Gomez says she's going to be a couple minutes late, but I'll call Jessica. Okay, come back. Brenda Johnson.
Here.
Good morning. Bill Kramer. Okay, no Bill yet. We have Sandy Sampson.
Present.
Good morning. John Santa. Okay. Maybe some people are getting a little bit of a late start. So let me just go back and see if anyone has just joined us that we didn't hear from. Ebony Clark. All right, Jessica Gomez. Or John Santa.
I see John's name on the screen.
Yeah, I see John, and I see Bill Kramer. Bill, just confirming you're here.
Yes, I'm here.
Okay. All right, so it sounds like I'll just connect to make sure John has audio, and I know Jessica's on her way and Ebony Clark is coming too. So I think that can wrap up the agenda roll call. Thank you.
Tara, do we have quorum to be able to take votes? Or shall we wait on?
We have 4 of 8. So I think, well, if we have John, if John has audio and can hear us, then that is 5 and that is quorum.
Okay, well, hopefully that gets sorted out. Welcome everybody. I guess I went through the housekeeping just a little too fast. This is the June meeting of the Oregon Health Policy Board. And I'd like to start by just taking a moment to acknowledge the atmosphere and times that this meeting is happening in, including the cycle of headlines around mass shootings, Roe v. Wade news, and more, just that people are hurting, angry, feeling many emotions. And I ask that we bring compassion for one another and some grace as we continue our work and navigate this meeting and our days. I also appreciate your patience as I chair my first meeting. So one more bit about housekeeping. So to everybody listening to this or participating in this meeting today, we do want to highlight that with David Bainsberg's retirement last month, we have an open member seat on the board. So if you or someone you know are interested in becoming an Oregon Health Policy Board member, please visit the members page on the OHPB website to find information on how to apply. Applications are accepted on a rolling basis by the governor's office, so there's always a good time to apply. OHPB is considered an executive membership board, and all applications, membership considerations, and recommendations are overseen by the governor's office. Applicants are selected for the Oregon Health Policy Board membership, are governor appointed and Senate approved. Again, please see the OHPB website for additional information, and thank you, Tara, for putting it in the chat so everybody can easily link to it. So before we get started, I'll do a quick overview on what we'll cover in today's meeting. First agenda item is an Oregon Health Authority agency update from Director Patrick Allen. The Oregon Health Plan Redeterminations and Bridge Program Task Force will give us an update. And then we'll take our morning break and hear public comments. Members of the task force on universal health care from SB 770 will provide an update. And then we'll revisit the Oregon Health Policy Board's committee membership work group recommendations. These were presented at our retreat in April and in last month's meeting. And the last update we'll hear is on OHA's 1115 waiver renewal. Then we'll adjourn the June OHPB meeting. Are there any questions, corrections, or additions to today's meeting agenda?
Chair Isaacson, not for the agenda, but just for the record, I noticed that Jessica Gomez has joined us.
Excellent. Welcome, Jessica. Perfect timing, because our first order of business this morning is to vote on the draft May OHPB meeting minutes. The draft minutes are listed as attachment number 1 in the members' meeting packets and are posted on the board's website for public viewing. Is there a motion to approve the May meeting minutes?
So moved.
Second.
Thank you, Sandra and Bill. All those in favor of approving the May minutes?
Aye.
Aye.
Are there any opposed or abstentions? Great. The May meeting minutes are approved. So first up, we welcome Patrick Allen, Director of the Oregon Health Authority, to provide agency updates.
Thanks very much. I've got a few things to go over today. First, I wanted to give a quick update on behavioral health funding. We talked a little bit about this in my update last month. Things are moving apace based on what we talked about last time. In Measure 110, we now have dollars that have begun to be dispersed to behavioral health resource networks, or BURNs, across the state. The first 2 have been funded. There are 7 that are now lined up to be able to that have been approved by the Oversight and Accountability Council, and those are moving toward contracting. We anticipate somewhere around 13 or so counties having their BURN or BURNs approved by the middle of June. If that occurs by the middle of June, then unless something goes crosswise in the MOU process, we should be able to have those funded by the end of June. So we're pushing up over a third of counties that'll be done by the end of June. You'll remember from the funding timeline that there was a funding basically kind of window that ran from June to October. I think appropriately people kind of looked at the October end of that and got a little concerned that that's when all the funding was going to occur. I think we're certainly on a track now where that's going to be more front loaded than not, with some hangers on that'll be extending out into October. And that 13 would include some not just smaller counties, but Washington County, Clackamas County potentially. I know Umatilla County is coming up, so some larger counties are included in that mix as well. In addition to the Measure 110 funding, $132 million in one-time workforce grants to stabilize the behavioral health workforce is now out and in providers' checking accounts if they receive automatic transfers or checks are in their hands at this point now. If they don't, and so that money is out. And then additionally, we have $230 million in supportive housing and residential treatment program grants that are now in the pipeline. 100 million of that goes directly to community mental health providers, often counties, though not exclusively. That money is directly controlled by the counties, and then 130 million or so out through an RFP process. So those dollars are underway, though not out at the moment. And then finally, we have a significant amount of behavioral health rate increases that are in the pipeline. They're out. Basically, we distributed the proposed rate increases based on CPT codes across many codes to identify the different costs associated with different types of diagnoses and acuities. Those are out for public comment right now. We'll still need CMS approval and then ultimately the legislature to release the funds associated with those, but those dollars are also on their way out, and that the increases should be effective July 1st, and there'll be a retroactive payment if we don't have those federal and state approvals quite by the 1st, but we're on track to be able to get that money out. So that's everything on behavioral health funding. A couple of other things to hit quickly. We have just announced a change in postpartum coverage, extending postpartum coverage now to 12 months. About just over 40% of births in the U.S. are under Medicaid. It's at least that high in Oregon. A recent report from Health and Human Services highlighted the inequity in rates in pregnancy-related deaths that are 2 or 3 times higher among Black, non-Latino, and American Indian, Alaska Native populations compared to white populations, and that those 1 in 3 of those pregnancy-related deaths occur between 1 week and 1 year after childbirth. And so the idea of this extension, which has been approved by CMS, is to address that inequity, provide enhanced coverage, contribute to our overall goal of maximizing coverage and minimizing churn on and off coverage, and eliminate health inequities by 2030. We're really happy with that change, which is in effect now. And then finally, in terms of COVID, we're at an interesting place that appears potentially to be a peak in the most recent surge. Remember, peaks are now a little bit harder to identify because case data is pretty unreliable at this point. We know that at-home tests are a significant piece of the overall total. They're typically not reported, though there is a vehicle for being able to report both positive and negative tests to us. In the Delta wave, national research indicated that we were picking up about 1 in 4 cases. There's not definitive research on what things look like now, but numbers out there in terms of estimates range anywhere from that to perhaps as few as 10% of cases being diagnosed. And so when I look at those case numbers, I really don't try to compare where we are in cases now to previous points in the pandemic, but I do look at the direction. If the reported cases are going up, cases are likely going up. If reported cases are going down, they're likely going down. There's just a lot of uncertainty associated with that. We are at about the level of hospitalization forecast by OHSU in its most recent model, though we're there a little earlier than their model indicates. So that would lead you to believe that we may overshoot that hospitalization mark by a bit, but still far below the levels that that created really significant stress on healthcare systems in previous waves. And so, what else do we look at to be able to identify where we are? The numbers that I look at most regularly are ICU admissions, which are not nearly as high as they have been. In particular, I've been looking at ventilator utilization. As of yesterday, I think there were 6 or 8 people in the entire state on a ventilator with COVID. That compares to something like 150 at previous peaks. And so that's an indicator that severe disease is much less significant in this wave than it has been in previous waves. Now, both hospitalizations and ICU utilization are trailing indicators. So the other one that I tend to look at is the percentage of people showing up in emergency departments with COVID-like symptoms. That's not to say that they've been tested and found they have COVID, but they're there with things like respiratory distress, fever, cough, those kinds of things. And they're sick enough to have gone to an emergency department. And that number has been bouncing around 4.5% to 5% for about the last month or so. And that number again in previous waves was up over 10%. And so the number of people showing up with sick enough to want to go to an emergency room with things that could be COVID again is significantly lower. So I think we are at that place we've been looking for, where there's a divergence between cases and serious illness, which is a really good sign. I think that's everything that I wanted to cover in terms of an update. Happy to answer questions.
Great. Thank you so much for the update, Director Allen. And we do have time for questions and discussion. And Sandy, I believe your hand was up first.
So, Pat, do we know what variant it is? I know you probably haven't been testing for it, but so that we know kind of what's in the Northwest. Is it the last variant that was going on? It was 2.1.2 point whatever. Are they testing for that or not? So
we do screen for variants. The data lags a bit, but OHSU and others do sequencing on samples. I don't recall what the most recent percentage of samples is. It's historically been one of the higher percentages in the country of sampling that we do, and we're certainly into the BA2 variant being the dominant variant that's here right now. But I think it's possible that BA 212.1, I think it is creeping up. We just haven't seen it show up in the data yet. And of course, the latest variants of concern are BA 4 and 5, which are beginning to show up in the Northeast. But I don't think they have shown up in our sequences here yet.
thank you.
Mm-hmm.
Hey, John?
Yeah, thanks, Pat. Any comments on the prospects for the fall? A vaccine that will work better for Omicron. Any your read on the tea leaves regarding what'll be available in the fall or late summer?
Gosh, I was disappointed when you first asked me about prospects for the fall. I was going to say I thought the Beavers year was looking pretty good as we're shaping up through spring. But no, I think I was just reading an article today about data that's being gathered on vaccines that have been developed or that are under development right now that are more particularized to Omicron. Of course, the trick is Omicron what? And as the variants have progressed in Omicron, what I understand is each variant seems to be getting more adept at escaping immunity, whether through prior infection or through vaccination. And so that's a bit of a challenge. There's also another vaccine potentially on the horizon, Novavax, which uses more traditional technology to produce that vaccine. There's a lot of speculation that what we may head into in the fall from a vaccine standpoint is some kind of a combined influenza COVID vaccine. I've seen more speculation than any hard information about that actually happening. So, take that for what it's worth. I think the general expectation is that is when our next significant wave will be. And I think the concern that I have heard reported is that BA 4 and 5 potentially show some evidence of looking more like Delta than Omicron in some respects, and that could indicate a more serious disease, but I think it's way too early to really be able to characterize that as anything other than speculation at this point.
Are there any other questions or comments from board members? Okay, then. Thank you very much for the update, Director Allen, and for all the work behind it. I believe you are on deck for our next agenda item as well, which the next agenda item will be kind of sectioned in two parts. So first, we'll hear updates about the Oregon Health Plan redeterminations work, and then we'll hear updates about the Bridge Program Task Force. We'll start with Patrick Allen providing updates on the redeterminations work, and then we'll have time for questions and discussions before we move on to the second part of the presentation. Pat, start when you're ready.
Thanks. I think we got a PowerPoint coming up, and apologies, I think I'm going to be talking entirely too much at this meeting. Jeremy Vandehey is unable to be here and sends his regards. So we're going to talk about the redeterminations as a result of the public health emergency. Let's go to the next slide, please. And just to give you a little bit of background, we're here because part of the response to the pandemic has basically been to make some significant changes to how people come on and go off of the Oregon Health Plan. In real simple terms, we allow people to attest to an awful lot of information that previously needed documentation potentially to be able to become eligible for the program. And then the ordinary process of once a year redetermining if someone is eligible has been suspended over the course of the pandemic. Everybody's membership is redetermined. And so it's not just people who've been added to the system, but everybody who's on the system. Or today about 1.4 million people who are all due to have their eligibility redetermined. We'll have about 14 months to do that work when the public health emergency ends. And what we've been given to understand from CMS is they will give us 60 days notice before the end of the emergency. Current emergency ends middle of July. May came and went without a notice, and so we're anticipating it will be extended. Everyone's sort of assuming that they're going to extend it as they have before in 90-day increments. There's no guarantee that that's the case, but it looks like it will not end in July, though we won't probably get the formal notification of that until potentially in the last couple of go-rounds. It's been a day or two before that expiration. Next slide. So this redetermination work is not going to happen in a vacuum, and we've tried to list here some of the things that are also going on at the same time. I'm not going to go through this list item by item, but as for example, we're ending the supplemental nutrition assistance program emergency amounts that have gone out to people. There have been timelines in SNAP that have been suspended. There is work going on in dental programs for veterans and for members of the Compact of Free Association. You probably note that these are not overwhelmingly OHA programs, but they're important because the eligibility system that operates around Medicaid is a joint system operated by Department of Human Services, and these are all programs that affect that same system and have impacts on the work that we are doing together. Next slide. So as we do this redetermination work, and I'm going to come back to this slide again in the presentation about the bridge plan, but basically there will be some options of what will happen as people get redetermined. First and foremost, the overwhelming majority of people will be determined to continue to be eligible for the Oregon Health Plan. If someone was on OHP because of a disability, they're unlikely to no longer be disabled, and so they'll still be eligible. If they were in any other kinds of those programmatic definitions that don't have to do with income, they're likely to continue to be eligible. We think there'll be about 300,000 people who will no longer be found to be eligible. And there'll be some options of what will happen. They'll be able to move to the new bridge program that we'll talk about in some more detail here in a few minutes. They'll be able to obtain coverage through the Oregon health insurance marketplace. And ideally, if their income hasn't increased too much, or they've not gotten other coverage, they'll be able to get subsidies for that coverage, or they'll have gotten other coverage. They'll have aged into Medicare. They'll have obtained employer coverage as they've gotten a job with those benefits, and so on. Next slide. So the whole point of this exercise really is to work to do everything we can to preserve coverage, the coverage gains we've made in the state. And part of what we're really talking about here is there are people who churn on and off of coverage. And that's really, we'll get into that more in the bridge plan, but it's really, how do we make sure that that churn doesn't become a permanent impact or a long-term impact that deals with people's access to coverage, and more than coverage, access to healthcare. So what we want to make sure is that people who are eligible for the health plan continue to stay on the health plan. That people who are no longer eligible clearly understand what it is they need to do to be able to get alternative coverage, and that the people who are providing help are able to have the information they need to provide that help and facilitate that process. Next slide. We're going to phase the redeterminations for getting people covered, and then move to the new bridge program. Does this one have more bullets, I think? Okay, so let's go to the next slide. That's fine. So when we talk about phasing, what we're going to do is we're going to phase people early who are quickly able to be redetermined and don't have a lot of risk or complexity to their cases. And so people that we have complete information, contact information, complete income information, those kinds of things, we'll go early in the process and basically kind of get them taken care of so that we can spend more time on people who are more complex. There are lots of reasons that people are going to be higher risk in the redetermination process. We've listed some of them here as some examples, but people who are receiving long-term services and supports in long-term care facilities, people who don't have a permanent address, they're houseless or have other circumstances, or their written and spoken languages of choice are not English. Those are some of the examples of people that will be at greater risk of losing coverage, that will want to allow more time, and we'll put them to the end of the redetermination process. Not that we're going to save them to the end to do the work at the last minute, but give us the most amount of time to be able to do that work to get them redetermined. Next slide. Again, this is one that I think I'll come back to in the next presentation, but there are, in terms of the bridge plan, there are some options about how we're going to be able to take a look at that. This is exactly what the task force is wrestling with now, but it has to do with creating a basic health program, or BHP. There are several federal tools in terms of waivers, and we'll talk about that in more detail in the next slide, or in the next presentation, excuse me. So what we've done is we formed a team across the agencies that kind of have prime time responsibility for this redeterminations work across OHA, ODHS, and DCBS. We've developed a plan for performing the redeterminations. We'll ultimately work together to communicate to members, providers, and partners to make sure everyone's got the information back a couple of slides ago to know what they need to do to keep their coverage, where they go if they don't keep their coverage, and for partners to know what they need to be able to do. And in terms of the complexity of what all's going on right now, we're trying to work to communicate that coordination across the different programs that are operated primarily by the two agencies, ODHS and OHA. And right now, we're especially focusing on getting people to update their contact information. I've often said, only about half tongue in cheek, that one of the biggest reasons people lose their access to the Oregon Health Plan is because they don't open their mail, or they don't get their mail, even more directly. And so we want to try to minimize that. Next slide. So let me just talk quickly about a little bit of the outreach work. As the slide says, outreach is going to be key. And what we're really trying to do is make sure that we communicate as much as we can on a person by person basis and give them sort of concrete to-dos of what do they need to do to be able to keep their coverage or as seamlessly as we can move their coverage to the new alternatives. Next slide. And I think I've really kind of already touched on this a little bit, but prior to the public health emergency expiration, which again, we don't really know the final date, is to focus on people updating their contact information, their income information, who is in their household, all those kinds of things that are necessary to be able to make redeterminations. After the renewal period, we'll focus on the to-dos. What do you have to do to be able to maintain coverage or get to the new coverage? Next slide. We've got a website that's up, that's got the things that you see on the left in terms of an updated timeline, links to program pages, materials for partners, talking points, that kind of thing, to be able to help facilitate that work. Next slide. There's a community and partner work group established by the legislature to advise us on how to do this work. You can see the guiding principles here are around health equity, using community input, and centering people who are directly impacted by the redetermination work. And it's made up of people who are on OHP, community members, tribal representation, representatives, health systems, labor, those kinds of things. And their monthly meetings just began here about 2 weeks ago. Next slide. So there are some obvious risks, and this is a process that we've done large-scale redeterminations before, so we know that there are challenges and things can go potentially sideways, and that's absolutely true in this case. And there are lots of opportunities that this may also go sideways, despite our best efforts otherwise. I'm not going to go through everything that's here, but I'll talk about some of these. As I've already mentioned, we don't really know when the public health emergency is going to end. We think it's going to go through October. There are rumors that it may continue through the end of the year. We just really don't know. Historically, we don't have a lot of accurate information for contacts, emails, phone numbers, those kinds of things. And so that's a challenge for that person-centered, member-centered outreach. There is a lot of volume of tasks that we need to serve current members. There's an existing backlog in doing current work around eligibility that will have an impact. We've got some challenges in the call center with some lengthy wait times. The plans are in place to be able to drive that down as best as possible prior to this work. But I think people making phone calls is going to be a challenge for getting through. One of the bullets talks about eligibility workers lacking familiarity with the process. This is not the kind of work that we can, call in volunteers or guard members or other strategies we've used in some other areas, because the amount of training necessary to do eligibility determination work is really extensive. We do have a contract with PH Tech to help with this work, but the actual eligibility determinations decisions by federal regulations have to be made by a state employee. We can't contract that work out, and so that's a limiting factor as well. Next slide. We've talked about the compressed timeline, or we've talked about the timeline. And basically the 14 months isn't really 14 months to make a decision. The 14 months includes appeal processes. And so what we're really talking about is work that would ordinarily be done over about 12 months over the course of a year. As we're doing redeterminations in the ordinary course, will need to be compressed into about a 9-month period as we get through this work. And again, a call out that's happening at the same time that there's work going on with changes in SNAP, temporary assistance for needy families, employment-related daycare, and other programs. Next slide. So this is just a little bit of what's the current workload that ODHS is facing as it does redeterminations work. And you can see the kind of the light blue at the bottom is sort of keeping up with current work. and the fork that's been relatively steady since March, and they expect it to continue to be steady. A little bit of a buildup in some past due work, and then renewals and changes are the blue boxes on the top. And so you can see that there's a fair amount of pending work that's in the system now that's going to need to be managed along with new work from redeterminations. And that's probably the biggest risk facing the system overall. Next slide. So the staffing, if you were to go out and sort of hire every last person you could to do this work, the number is pretty significant. My recollection from Fairborse Paxarash, director at ODHS, presenting this information is that it was upwards of 2,000 employees to be able to do this work. We're not going to be able to be staffed at that level. There is staffing being added, but the training lead time is, as I indicated before, significant. And so we will see these kinds of issues around backlogs, delays, wait times, those kinds of issues as a part of this process. Next slide. So let me stop there, and as Chair Isaacson indicated, before we dive into the next presentation, see if there are questions I can answer.
Brenda, please.
Thank you so much. I really appreciate the briefing. And of course, it's concerning based on the time delay in the volume. So I appreciate the heads up for it. I'm curious if there are workflows contemplated or currently in existence where the community assisters have direct channels of communication with staff, with state staff to help. I appreciate 2,000 humans doing this kind of work is likely impossible, yet when we distribute the work within community, we have greater opportunity. And I know sometimes getting a hold of people at the state can be really challenging. So I'm curious if you have a different pathway for those that are doing the assister work compared to the larger population needs. Yeah.
Yeah, thanks for that. And my knowledge is a little bit limited here, so bear with me on that. We may need to provide a little bit more detailed briefing back in writing, but my understanding is yes, that we are working differently through community assisters and working through some federal limitations on who can and can't do what to try to facilitate that process. But especially in this early stage where it's it's pretty straightforward stuff of make sure your address is accurate and that you've got a good email and that we know basics about your household circumstances. That work really lends itself to assisters and can really speed up the process when we get into redeterminations.
Thank you. John, your hand was next.
Yeah, thanks. Well, first of all, Pat, I've had some personal experiences trying to help some colleagues, and it is incredible how hard it can be to make progress if you can't figure out whether they're getting mail, what they're doing with their mail, if they're struggling to access their computers, their phones, boy, it's really been driven home to me how really simple administrative processes for maybe some of it is pandemic, but in the midst of illness and stress, it can be very difficult to figure this out. Is there any role for volunteers here to help? I mean, the state has a cadre of impressive volunteers. I know a lot of people my age are, out there volunteering in a variety of ways to help. Likely, of course, volunteers, could probably not help with the more complex eligibility process itself. But are there other things that volunteers could do here? Because I think a lot of folks would, I think of the ServOr and some of the volunteering stuff that went on with COVID is pretty incredible. And can that be tapped in any way to help in a more concentrated way or period of time?
Yes, but I think the most effective way to do it is through community-based organizations and assisters. I think it's unlikely for it to be effective for us to, create a server-like kind of a function in this space to operate at a statewide level. It's going to be a lot more effective at the local community-based level, where if someone is likely to have a relationship with an organization or with people in an organization and be much more comfortable using those volunteers, and I think they can be used more productively in that kind of a setting.
Great, thank you. Bill?
Thanks, Patrick, for this very good presentation. I'm very impressed by all the planning and thought that it's gone into this. This is enormously important and enormously complicated logistically. I was building on the comments and questions from Brenda and John. I was thinking about the community and partner work group. I understand that group has just started getting going, but I understand they did meet for the first time in late May. And I wondered if anything came out of that, if you see them as a group that might be able to help with ideas and even referrals to help with the outreach and enrollment process.
Yeah, I'm looking forward to that group's advice and input, especially since it focuses on community partners, members on the Oregon Health Plan, who directly deal with this and are impacted by decisions. I think the first meeting was more, getting started, organizational in nature, but I think that group has got a powerful opportunity to help us really develop systems, tailor how we're doing the work, and provide ideas for how we can make sure, again, that we keep people's coverage as intact as we possibly can, or make it as easy as possible for them to transition to other coverage.
Great, thanks, Pat.
Mm-hmm.
Sandy? Next
So,
one to you.
thanks again. You said that CMS first had stated the redetermination process would end in the end of July, possibly, but they're only going to give you a 60-day notice. Is there any negotiations with CMS I mean, that's a lot of people, 1 million people to get. I mean, I remember when I retired and I went back and started doing some of this work, it was very difficult and I know we kind of had some great discussions, but to get this done in a community setting, and then get the applications processed. I don't know how it's running now, how smooth that process is running now, but when we expanded Medicaid with the FPL way back in the day, 2013 for 2014, you have to have community buy-in and a big fair. So to get all these individuals redetermined. So what kind of marketing strategies does OHA, DHS have as far as with the one system? There was never supposed to be any delay, and it ties right in with kind of what our community partners are doing now. So it's a big process, and not having the marketing strategies behind it is our materials started ahead of time. I mean, we're in June, we got a month and a half, so I'm just curious there.
Yeah, so just to be clear, I think we have longer than a month and a half. The clock starts running with the expiration of the public health emergency, which we now do not believe will occur as currently scheduled in July. We think it'll occur in October or potentially later. So that's good news, because that gives us more time before that clock starts running. We absolutely do have a marketing strategy and materials and development and all those kinds of things that you talk about to work on how we're going to communicate with members, how we're going to communicate through partners and those kinds of things, as well as how we'll communicate through CCOs who already have a relationship with 85% of the 1.4 million people on the OHP. So we are working to move down that path. Once the public health emergency ends now ostensibly in October, then we'll have that 14-month period to be able to do that work. And again, that gets into the stratification of the population to focus first on people who we think we can do quickly because we have all of that current information. Gets into why we're trying to focus right now on getting people to update all of that information so we can get as many of that 1.4 million people into that first box of we've got complete information and we're ready to go to get them taken care of, and then move on to people who are going to take more time because it's going to take more outreach.
So with that said, do you have materials out so that we can make sure, like SNAP eligibility, it's, you know, if they're still in that same category where, you know, their FPL has not changed much, that is the strategy you're using now, so that like I can get a hold of my clinic and say, hey, you've got to start doing SNAP individuals first, or how are you communicating that for SNAP or TANF individuals?
Yeah, so I think what I'm going to need to do is have staff follow up on the details on how that's working, and we can get that out to the board.
Thank you.
Mhm.
Thank you. Jessica?
Yeah, so my question was around more the fiscal impact of some of this. So if we're going to be maintaining coverage for quite a few of those people, is what I would assume. Do we have a sense of what that's going to cost? Because the state has a percentage that we pay of that coverage, and then what is it, like 6%, if I remember correctly?
About, yeah.
And then do we know what the potential impact would be on private insurance premiums? Because in some ways we're talking about a big balloon, right? You know, you squeeze one side and the other side, the cost kind of goes up depending on kind of how hospitals handle their contracts and how they balance their expenses. Have we looked at any of that? Because we've got a really big issue with you know, just a very, very expensive premiums for the other, you know, 60% of people that are on private market insurance.
Yeah, so you're exactly right. There's an enhanced federal match of 6-point-something% that we get right now that tracks with the public health emergency and will ultimately go away as we redetermine people out of the system. That will put people who remain in the Oregon Health Plan back on the sort of the standard funding mix. We've always known that we were not capturing a chunk of people who were eligible for OHP to begin with. And so hopefully as we come into this process, we'll sort of improve our performance and get more people who are eligible on OHP. That's good for them and for us because they're more likely to be healthier, and connecting them with primary care and coordination through a CCO helps keep them healthier rather than being enrolled just when they get sick and need healthcare. In terms of other costs in the system, at its next meeting, the Bridge Plan Work Group is going to hear an actuarial analysis on various options to see what costs look like in those systems. And the knock-on impacts to private health insurance are really probably going to depend on what path we end up going down in terms of the bridge plan. But of course, the advantage to people being on the Oregon Health Plan is not only is there federal match, but there's also a cost containment structure around reimbursement rates. Those shift as you move into different elements of different costs. And you need to know how certain parts are moving before you can ultimately identify how they're going to move in the private market. But we should know more of that as we get through those actuarial analyses.
And so the other follow-up question that I have is, do we know anything about sort of the impact on the workforce? Meaning, you know, if you're on OHP, you've got pretty good insurance and there's no out-of-pocket, right? if you're somebody, like me or somebody who works for our company, we've got a $4,500 deductible and a 20%, that has to get paid out if you have to, if you have an incident or, you have to be hospitalized for whatever condition you have. If you're, let's say, somewhat middle income and you've got a sick family member and you're paying that whatever $9,000 out of pocket, in a lot of cases, you might be financially better off just quitting your job and getting on OHP. Do we have any sense of what that tipping point looks like and how we're gonna try to encourage people to stay employed as they maybe have some of these events? I mean, it happens all the time. We see that a lot on the employer side.
Yeah, so I think anecdotally we see stories of that, and I'm as big a fan of anecdata as anyone. But I think you don't see that roll up into it being an actual substantial thing that happens at scale in the economy. We're at near historic low unemployment rates right now. The labor force participation rate has been increasing rather than decreasing. If that was pervasive, you would expect the forced participation rate to be going down as people simply choose not to work, and we're not seeing that happen. So I think the trade-off for most people of being employed works out in favor of employment, and we see that in the aggregate numbers in the economy. That's not to say that.
Yeah.
Go ahead.
I'll have to look, because the latest numbers that I saw on the participation rate, the last time I looked at it, we're the lowest we've been since the 90s in actual workforce participation. So that's everybody who's working age, who's looking for a job or collecting unemployment. And it's
I'll check
low.
too. I'll check too. I think that dropped during the early part of the pandemic, but has begun to rebound again. The point that you raised earlier, though, I think is still a good one, which is because we have this patchwork system of health insurance, there are major gaps in effectiveness in it. You're going to hear some from the 770 task force later around universal coverage. I think that patchwork element raises lots of cost and leads to ineffective access to care. And that's part of the long-term mission is to figure out how to make these systems work better and provide better care for the dollar. Because as we've talked about over years here at this board and elsewhere, we pay more than anybody else for coverage in the developed world and get worse coverage and worse health outcomes. And so I think that this is part of the overall effort to try to change that dynamic.
Yeah, and I mean, I understand sort of the goal, right? But my concern is that, when we put in place mechanisms like this, what we're doing is we're just pushing the cost up more, meaning, we're sort of moving the water line, but we're not actually dealing with the gap. And that has the potential to just increase costs for everyone else. And now you've got families that have two working parents that are actually worse off than families that have maybe one working parent that are eligible. And so you get into this, sort of situation where you're narrowing your middle class, right? So your people who've got plenty of money have no issue. But those people in the middle that are trying to build in what I would call like economic mobility and are really working hard at it, continue to struggle, and it becomes just harder and harder to do it as you see these programs try to address that. But it's not getting the overall job done. So I just wanted to, bring some attention to that and, just make sure that there's actually someone who's really looking at just the overall system, because there's a lot of moving parts here. And I'm really concerned that as we try to help less fortunate, we're making it more difficult for people to really gain that economic mobility that we really hope to facilitate as part of these safety net systems.
Yeah, I think that's a great point, and I think it really calls out the fact that that is in fact the role of OHA and this board, is to look at the overall system. That's why we have efforts like the cost growth containment task force that is responsible for looking at healthcare costs generally, how they show up in people's pockets, and why we've created a system to really manage those costs and try to hold those down to that target that's basically shaped by the actual growth of the economy.
Thank you.
I also think the second half of this presentation, as we get into more the bridge program part of it, they do have a kind of broader view and thinking about the implications of this work. So I look forward to getting into those details. There was a question that came through on the chat that I'd like to raise up, which Director Allen, you discussed kind of limited agency workforce capacity to meet the volume of renewals. Seems, in other words, seems like OHA needs more staff to do this work, especially once the public health emergency is lifted. Will a request like that go to the legislature in the 23 session?
Yeah, it's actually ODHS that needs the staff to do the work, because they're the agency that actually operates the integrated eligibility system and the systems that go around doing that work. They have been adding staff over the last several months to be able to accommodate the work, and so but they're faced by the same sort of workforce shortage issues that everybody else is, and so I think what we've tried to highlight in the presentation is that despite best efforts to staff up, there's going to be a time and supply set of limitations around that, in terms of the lead time to get people trained and the access to workforce challenges that they'll face in doing that work.
And to that end, it feels this is a lot of important work ahead, and you've outlined some challenges, some which are being addressed, some which are hard to address, which I don't know, I keep thinking like, it feels like we got to do more work, harder, faster, less. Sorry to actually say that out loud, Director Allen. But to that end, I would like to think that the work group that is in place would help illuminate some of those efficiencies that can be gained through working with partnerships, or I think about past presentations we've had kind of saying like, oh, I got this letter from OHA about this not being covered, and I don't understand the letter whatsoever. But there's improvements to be made on many levels to make this work accessible and faster for people to move through. I'd love if you could mention a little bit more in detail about the task of that work group, and also how the public or this board can kind of stay connected to progress being made both within that work group and this larger effort.
Yeah, thanks for that last point, and I neglected to mention that earlier and should have. I think what we would want to propose is that we actually bring redeterminations work back to you as a kind of a monthly standing item, where we talk about work coming out of the work group, and then just what's going on in terms of redeterminations. I think early on, for the next couple of months, it's likely to be more focused on preparations, materials, communication with partners, those kinds of things, before we actually get into the actual determinations after the expiration of the PHE. But I think the transparency from that standing item would be really helpful if the board is amenable to that.
I'd love to hear thoughts or reactions from fellow board members on that. I feel like this is an important effort in the state that feels like it's going to be hard. And so how having a public space where we are kind of taking its temperature regularly seems important.
Yes, I would agree. This is Bill Kramer, that this is so important. And there are a lot of risks, as Pat described, and I don't lack any confidence in their ability to do this, but it is worth, I think, close attention over the coming months. And if there's any support that we and other stakeholders can provide.
Yeah, I'll echo Bill's sentiment and just encourage us to take the focus of really active communication. So what role and responsibilities we have when we think about the community engagement, what we're really asking people to do, and that they feel confident with the tools to do exactly what we're asking. So I look forward to the next, I look forward to all the updates. Thanks.
Great. So yes, please, Director Allen. And the OHA staff who put the agendas together, we would enjoy and appreciate hearing updates about this effort in our monthly meetings.
We will make it so.
Thank you. Great. Any other questions or comments from board members? Okay. Seeing no hands raised, I suggest that we move on to the second portion of this update. It's companion with the Bridge Program Task Force.
And I think I'm going to kick this one off as well. So I am joined today by Stephanie Caballero, who is the board's designee on the task force, as well as our staff member, Lauren Swerdlow, who are going to take some of the presentation as well. But let me go ahead and dive in to start. Next slide, please. So we're going to, 4 topics. We're going to give you a quick refresher on what the task force is and what it was charged with. We're going to talk some about the in-depth conversations we've been having with CMS and others, and how that's shaped the direction that some of these paths are going to take. We'll talk a little bit about the task force's work so far, and then focus on what the timeline looks like and the key decisions and next steps that need to happen between now and September. Next slide. So just a quick word about Medicaid coverage and sort of how some areas have changed. Our rate of people being insured in the state has gone up over the course of the pandemic. And you can see there are sort of 2 dynamics here. One is a pretty substantial increase in Medicaid enrollment. About 30% of Oregonians now get their health insurance through the OHP. A somewhat smaller decrease in group insurance enrollment. That's a trend that really goes clear back to the beginning of the Affordable Care Act and has continued through the pandemic, and has not changed as a result of the pandemic that I'm aware of. Also, buried in that 1.4% increase in the insurance rate is a pretty significant 3 percentage point increase for Black African American Oregonians. And so we can see that those increases in coverage are really occurring in ways that help us achieve our goal of eliminating health inequities. Next slide. If you then look at insurance coverage rate by rate of income, you can see that where we're really making major gains are in this range of 138% to 200% of the federal poverty level. That's just above the rate that's eligible for the Oregon Health Plan. I talked in the last presentation about the population that move on and off the Oregon Health Plan, either for lack of our being able to communicate with them to determine that they're eligible, or they're slipping just in and out of eligibility based on seasonal work, job loss, a variety of circumstances that causes their health insurance to really be quite unstable. And that's a part of what we want to focus on. On the right-hand side, we do a survey to ask people why they're uninsured, and the percentage who identified having lost their OHP coverage for the reason that they're uninsured has dropped pretty significantly over the course of the pandemic. Next slide. So again, just to refresh your memory on the slide I showed you earlier, about 300,000 people we estimate will be determined not to be eligible for OHP anymore, and they'll have options around obtaining other coverage. getting their coverage through the health insurance marketplace or pursuing the bridge program. Next slide. So the task force was charged to develop a proposal for a bridge plan, with the idea being to really focus on continuity of coverage and provide affordable coverage that people were able to move to if they're no longer eligible for the Oregon health plan. And again, really focusing on that population that enrolls and disenrolls. Next slide. The original vision, and things have changed, or they're beginning to evolve, I would say, a little bit as we move forward. First and foremost is to focus on people who are in that 138 to 200% of the federal poverty level, just out of range of being eligible for the health plan. And not only maintain their coverage, but keep them in their coordinated care organization, which leads to keeping them with key medical relationships, their primary care physician, their OBGYN, their oncologist, if they have one, those kinds of relationships that are highly disruptive if they not only lose coverage, but have to move to a different source of coverage that has a different network. We really want to keep people where their care is centered. The vision was for there to be little or no cost to enrollees, as is the case with the Oregon Health Plan, that the benefits be robust, and ultimately that people have a choice between a basic health plan product and moving to subsidized coverage in the marketplace. I'll come back to that point and talk a little bit about why we think that's beginning to maybe fade a little bit as a potential outcome as we learn more and work with the federal government on the options. Next slide. And so just quickly to give you an idea of who's on the task force, there are 4 legislators, 1 member of the House, 1 member of the Senate are the co-chairs of the workforce, and then you can see the different breakout of folks here. I'm not sure exactly where I'm supposed to hand off, but let me pause here and see if Stephanie wants to take a quick second to introduce herself as the board's designee.
Thank you so much, Director Allen. My name is Stephanie Caballero. My pronouns are she, her, ella, and I am actually the Oregon Health Policy Board representative on the task force. And I'm thrilled to be here today to share a little bit more. You're doing great. My slide hasn't come up, so you can keep going, and I'll share a little bit more about myself there, and also some of the topics and conversations that we've been having with this committee.
Great. Send up a flare when I'm supposed to stop talking. Let's go to the next slide, please. So just in terms of kind of the structure of meetings and what's being talked about, these task force meetings are incredibly packed with information and discussion. It's really incumbent on Stephanie and the other members of the task force to do a lot of homework between meetings to be able to be prepared for these discussions. They've all done a really great job. You can tell by the discussions that people are engaged in. They've done the homework and done the reading that needs to go into that. Right now, we're coming up on the June 14th meeting, which we'll go over the actuarial analysis that I talked about. Meeting after that, we'll get into things such as what Jessica raised around market impacts, mitigation strategies, those kinds of issues. All of these topics really kind of build step by step to the final meeting, or the meeting in September, where they'll make their final bridge plan recommendations, and then a follow-on to report on strategies to ensure market stability. So a really tight agenda with a lot of information and some pretty weighty decisions to make. And then you can also see on the right-hand side, we've got kind of a federal feedback loop. We've been receiving that feedback, and I'll talk about that here in a second. Next slide. So just for a little bit more grounding, there are 3 federal tools to use to be able to do this work. The first is the Section 1115 waiver. This is the same section that when we talk about the waiver with a capital T and a capital W, we're talking about pursuing on our 5-year increment, but you can do other 1115 waivers. And one of the things that we'll talk about is the likely need to pursue an 1115 waiver in the short run to make people eligible under the existing OHP system at coverage rates above 100 or income rates above 138%. There's then a 1331 waiver, which is what would be used to establish a basic health plan. And I think you'll see that this becomes our primary tool for how to be able to provide that coverage. And then there's a 1332 waiver, which is a state innovation waiver. And this would be the tool that we would use to provide a choice element to the system. The biggest issue between 1331 and 1332 is they have very different underlying financing structures. And so there's a lot of flexibility that goes with 1332, but it comes at a price in terms of the cost of the system. That's a big piece of what we're going to talk about at the next task force meeting around the actuarial analysis. But we're already beginning to see the shape emerging that that'll really drive our ability to be able to pursue a choice system. Next slide. So this is it tries to kind of give you a little bit of a graphic of, I guess the assumption is you're mowing this grass and there are rocks in it, and so you may run over them. One big rock with an 1115 waiver is that the federal or the state match rate is pretty significant. However, that's already been budgeted in the bill that created the task force and set us on the path of coming up with with this bridge plan. And so at least it's been budgeted in the short run. It's not budgeted as a permanent solution to the system because of that 40% match. 1331 waiver has got a collection of smaller rocks, and we've tried to capture them here. There isn't the ability to have an option of being on or off the marketplace or in the basic health plan. There's potential impact in the marketplace because you're really talking about taking a fairly significant amount of enrollment from the marketplace to the basic health program. In 1332, you can see what there is a collection of a lot of rocks, some of which are big, and there's a big time constraint that I'll show you here in a minute in terms of being able to when we would be able to roll out a 1332 innovation waiver to be able to do optionality. Next slide. So we've been engaging with Centers for Medicare and Medicaid Services throughout development. They've been extremely helpful, are very interested in supporting our trying to move down these paths. And from those interactions, we've really kind of come up with some phases of what a bridge plan would look like. There's sort of a phase 0 before you actually do a bridge plan, which is to expand OHP beyond 138% of the federal poverty level, to basically solve the problem of people being found in redeterminations to be ineligible, and what do we do to preserve their coverage. That then moves you into a phase that creates a basic health plan for those OHP enrollees at the 138 to 200% level as a temporary step. You would then move on to sort of a full basic health plan, the 1331 waiver that would cover everyone who's in the 138 to 200% level, whether they're losing OHP coverage or not. And then there's what I'm beginning to think of as an optional phase 3 that really looks at choice between the BHP and marketplace coverage. Next slide. What we then try to do is capture that on a little bit of a timeline to give you a sense of when we're talking about. I talked about time constraints for any kind of an option of choice product, which is the red bar, the 1332 BHP-like product plus marketplace optionality. And that's really looking out into 2025, 26. And so we're a ways down the road to be able to implement that. I think that gives the task force some options about how to think about this in terms of what's considered a permanent step, what's considered an intermediate step, what's considered a step that you can then add on to later as circumstances develop or potentially change. Anymore after 2 years of a pandemic, 2026 feels like forever from now. So we'll see how that plays out. Next slide.
And I think this is where I step in.
There we go.
Well, good morning, everyone. Thank you again for giving us the opportunity to share a little bit more about all the meetings that are happening. As Director Allen shared, we've been meeting since April and have, I believe, at least 2 meetings every month, with a lot of homework ahead of that. And I briefly shared, I am your representative on the task force. I am actually one of the newer members of the Health Equity Committee that was appointed, introduced last December. And my interest in joining the task force really came from my own interest in being on the Health Equity Committee, but really bringing and sharing some of my own lived experience, professional, volunteer experience, and being a immigrant myself with very limited access and understanding of our own healthcare system here. So I really wanted to bring some of that experience into the discussions and contribute some of what we also see in my line of work, in what I do on when I wear my other hat, which, sorry, I didn't realize my logos here, but during the day, I am the executive director for the Virginia Garcia Memorial Foundation, supporting Virginia Garcia Memorial Health Center, and we serve a large population of communities of color in Washington and Mendenhall County. So part of my interest is also to share some of my own experiences in working in this particular line of work. And I'm pleased to be here. And my focus for this morning is going to be infusing a little bit more of our own discussions as task members, and the OHA staff and everybody really brings a rich discussion to each of these meetings. And the information for someone who initially shared, my hope was to learn more about our own healthcare system, has been extremely helpful. And so most of these have been in response to those discussions, the information that has been shared. Next slide, please. So as we think about where the task force is going and where we should focus over the next few meetings and what our steps will be, and also given some of the guidance from CMS, we will be focusing primarily on designing a plan for a basic health program through 1331 waiver. And our hope really is that if we have time, because we have a tight timeline for when we need to submit this proposal, that we will then return and think about a phase 3, potentially later this summer, as part of the report that we will need to submit by December 31st. And so, you know, a lot of that has come up in our own discussions too, is what would that transition look like if we were to go from that 1331 to a 1332? And we saw that visual of some of the challenges, but I think there's a lot of appetite to dive a little bit deeper into that if we have the time. And one of the interesting pieces that have helped me as a task force member, and I know have also guided a lot of the discussions, is looking at what we've learned from other states and our own history. We have learned a little bit about Minnesota and New York and what they've done. Our hope really is that we can continue to look at some of those models and some of their challenges to help inform our own discussions and our own plan design as we move into that in this next meeting next Tuesday. Specifically, what the task force has shared in terms of what would be helpful for us as we move along the planning is we really would like to have more details on the specific demographics of the individuals, Oregonians, that will be impacted by our work and our proposal. We would like to know more about the geographic distribution across the state and also the health status. We all agreed that would be really helpful in really thinking about the design and how to best impact all levels of what the coverage will be, what some of those copays and just those controls that we'll need to think about as we move into this design phase. We've also discussed the program's impact for revenue impact for the safety net providers and federally qualified health centers. We understand that many of us are the ones delivering the care. And so we want to make sure that the design also, the plan also takes that into consideration. And what will be the cost, that out-of-pocket cost for the individual marketplace. And again, just really thinking creatively around, if we do this, what's it going to lead? And that's why I think we keep coming back to the demographics and who is it that we will be impacting through these decisions and proposals. The other interesting conversation that has, or kind of question and concern that has come up, is what would the impact be for smaller coordinated care organizations and the effects on the entire system? We saw, hopefully you had an opportunity to see through the listing of who makes up the task force. We have representation from CCOs as well. And so that has come up, and making sure that we keep that top of mind, and how will the smaller CCOs be able to absorb the cost and comply with any changes that may come from this plan. And the other piece, which is very similar to the discussion that was we were having prior to this presentation, is really thinking about who's enrolled in Medicaid and who will transition into this plan. What percentage of Medicaid will be entering, or what percentage of them will be entering Medicaid via this presumption eligibility definitions in hospital versus other channels. And other conversations have been, how do we reach them, right? What will be our communication, and how will we make sure that we do so in a way that really meets their needs, similar to what has been voiced here previously. And I think that is the end of it. Yes. And, we invite you to, if you have any time, I know I've been to the meetings and there are a lot of time constraints, to join those task force meetings. They really are extremely interesting, and learning more. And again, starting next meeting on Tuesday, we will begin the design phase. So it should get even more interesting, and the discussions should be more involved. And I'll also invite Kirsten. I know you're part of the task force, so please feel free to chime in, and anybody else who may like to add your own experiences as members and what you've experienced through those discussions.
Thank you so much, Stephanie Caballero, for being the board's designee and serving so effectively on this task force and participating. We really appreciate it. Before we move into comments and questions from board members, I did see Laura Swerdlow pop up on screen, and I just wanted to give you the opportunity if you wanted to add anything else before we open it up for questions.
Nothing else to add. Thank you so much, Kirsten. My name is Laurel Swerdlow. I use she and her pronouns. I'm the Bridge Program lead, and Stephanie and Director Allen did a phenomenal job summarizing their work to date.
Excellent. Well, thank you both for being here. I'm sure there's a lot of questions and comments, and I see Sandy's hand up already. So Sandy, let's start with you.
Thank you. So, Pat, Oregon legislature commissioned two BPH studies in 2014 and 15, but did not go with the advisory group recommendations. Is there a reason that happened, or where can we get that information to review to see why that didn't occur?
Oh, great. I'll just do a brief announcement that Director Allen had to step out due to an emergency, sends his regrets, but we are in good hands with Laurel, and I think you're ready to answer that.
Yes, absolutely. It's a great question. And this has been a conversation that the state's been undergoing for several years at this point. There are a few changes in federal funding that have really led us to want to reconsider this pathway forward. Additionally, wanting to take advantage of this moment in time, as Director Allen underscored, over the course of the pandemic, there's been this enormous uptake in folks who are covered. And this is really a moment in time where we want to be able to ensure that folks are able to hold on to that coverage moving forward, regardless of the fact that the public health emergency is expiring. So you're absolutely right that those that this has been considered, and we're really using this time to be informed by the work of those previous task forces, and also reconsider the options on the table so that we're able to hold on to the coverage gains of the public health emergency.
And then where could we find this information to review?
Yeah, absolutely. Those reports are made publicly available on OLIS. What we can do is we can make sure to link to them in the Bridge Program Task Force website, and I can drop that website in the chat here.
Thank you.
Yeah.
Yes, great. John.
Yeah, I just think it's great the state is doing this. If you know, because of this crisis, there's an opportunity to do something innovative and creative. And Oregon has a track record of not passing up those opportunities. And so I think it's terrific what you all are doing. You know, my major caution would be the key is where the sick people are and what's happening to the sick people. And when are you going to move them? And if the environment you're moving them into is one in which they won't be desirable, and the various participants will try to avoid them, when they'll be subject to substantial cost sharing, which means they won't get what they need. I think you just need to be really careful. And so part of this, I think, is being upfront about trying to identify, to the degree you can, and the methodologies to do so are not perfect. They're far from perfect. But who is sick, and who really is not going to thrive in a competitive system. I think it's great what you're doing, and look forward to watching how things go.
Any other questions or comments from other board members?
I just got a quick one, real quick. So on your hospital presumptive eligibility, will you continue to do that 22, 23? Because what happens, people wait until they're hospitalized before they actually are actually being assisted to get on to Medicaid. So I've seen that I've seen people that should have been on the Oregon Health policy, the Oregon Health plan, but they just waited too late. And then sometimes that redetermination or the presumptive eligibility in the hospital becomes kind of hard for them, because whether they're still awake or not, or they're really sick with the reasons of being hospitalized, it gets really complicated to get them to sign paperwork and so forth. So would that still continue? And then are they does it still go back to when they were hospitalized for, or that month for presumptive?
Thank you, Sandy. I know that the question of presumptive eligibility was a question that was being tackled as part of the 1115 waiver process. I wanted to see if Trilby, if you have a sense of the status of that question in the 1115. This isn't a question for the Bridge program team is not taking on this question, and I believe it is being considered as part of the 1115. I just don't know the status of it.
Thanks, Laurel. No, I'm afraid I'm not able to contribute a lot more than you can on the status of the 1115. The connection that I see to what Sandy is raising knowing that hospital presumptive eligibility is not the ideal pathway to getting people back into coverage, and that the bridge program and this effort to keep people in coverage and reduce that churn where people fall out of coverage and then have to rely on presumptive eligibility to get back in, that is one of the goals of the bridge program. And so what I'm thinking is that as the bridge program is advanced, we should see less reliance on presumptive eligibility. So I see that connection here, and we can get back to you with any changes to presumptive eligibility that the waiver, going back to Pat's reference, capital T, capital W, might make, because I'd have to get more information on that.
And if I may add, that was in my slide. That was one of the key concerns that was brought up at the May 10th meeting, to follow up and make sure that we're keeping that top of mind as well as we think about how to roll all the different waivers and plans.
Wonderful. I really appreciate both of you being here today representing this effort. And I just want to acknowledge, if we think back several meetings ago in this board hearing about the initial redetermination process and where our uninsured rate was, and just identifying like this is a time to stretch. This is hard in a moment of a plethora of work, but it's a stretch that we need to do to achieve our goals around affordable, accessible, and equitable healthcare in the state of Oregon. And so I'm happy that we are receiving this update today. And to Jessica, I've been playing your earlier comments in my head and becoming even more excited about this effort, because one thing that I will say about the Bridge Program Task Force is it is focused on how do we keep our uninsured rate low. And how do we make sure people are able to access and afford the care that they need when they need it? But I also appreciate that there is a look about, okay, and how does us doing this impact what happens in the exchange? What are the rates that are going to be paid under the Bridge Program plan, and how does that impact those providing the care? And so I will say that the charge of the task force is very well-rounded, and as it should be. So I'm happy about that, and look forward to seeing how it progresses, and hopefully we're able to thread all those needles. Jessica, I see you coming off mute.
No, that's great. Thank you for that comment, and it's great to hear that that's something that everyone's looking at.
Yeah, it's a sign of a good collaborative effort, I think, and having many voices at the table. Speaking of voices at the table, I wanted to pose a question to board members. Having this update today from Ms. Caballero as our designee was very helpful. I wanted to ask kind of how we would like to engage Stephanie for future updates. If anybody has any thoughts.
Thanks, Kirsten. I'm not sure if this is useful or not. I am just struck by the previous conversation of looking toward redetermination and monthly updates. And so to the extent that it makes sense on that cadence, that would feel very natural. However, I'm not sure that this model is going to move at the same pace and clip that we might imagine the redetermination work explicitly moving. So I would almost leave it back to the committee and the staff to determine when they've got material updates that they want to make sure we stay close to. Yeah.
I think that sounds good. And I do think that these are public meetings. The task force meetings are public. So it can be handled a little differently, but I guess we would like to put it back to Stephanie and Laurel and staff that we would like to hear a progress update later down the road about this amazing effort.
Thank you. We will think about the best way to bring that in. I just want to also thank the OHA staff. They were extremely proactive in reaching out and offering support and helping provide this update. And I'm sure that as we move along the planning, we'll continue to collaborate and we'll continue to ensure all of you have access to the latest information.
Great. Thank you so much. Okay, and with that, we everybody has earned a break. We'll take a 10-minute, well, we can take a 13-minute break actually, and we'll be back at 10:18. Thank you. It is 10:18 now, so we'll resume the meeting shortly. Please come back from your break. And we will start the next portion of our meeting with public testimony and comments. I see we have some of our presenters already on. I'll do a brief announcement and then we'll hear from our people who have signed up to give public testimony. So the Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with the kind of careful attention, respect, and honor that you deserve. We want to acknowledge that whole time in our meetings is to hear public comments. It's meant to provide a voice and perspective from that individual, and is not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that that doesn't feel like enough time, we encourage you to provide written testimony in which we commit to reading. To help us keep on time, we'll start a slide with a 2-minute timer for each presenter, and we kindly ask that presenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by board chairs and staff to determine the appropriate next steps. And board staff will communicate the next steps with each public commenter. So we do have a few people signed up for public comment already. If there's any more, please, you can send a chat message to Tara Chichak or raise your hand. And we do appreciate if commenters you're welcome to share your video while you're presenting public comment. We ask that you keep your videos off the remainder of the meeting to help reduce bandwidth capacities. And thank you, Tara, for putting stuff in the chat for our written public comments. It's great. Okay, so we will start off our public testimony with David Ladwig, please.
Hi, can you hear me?
We hear you great.
I've been a member of the Mid-Valley Health Advocates Legislative Committee since I landed in Oregon almost 3 years ago now. So I'm speaking with the acquiescence and approval of that group as well as myself. But the written thing I sent in is more detailed. But I guess my questions are, I know there's the Healthcare Cost Growth Target Oversight Board, which is just about getting ready to meet. But we were concerned about the information in the Lund report about the projected increases asked for by many of the commercial health insurance providers. So I'm wondering if there's any consistency between the data that the Consumer Board sees and what's going to the Healthcare Cost Growth Target Oversight Board. Because I see that two of the first two values of OHAO overall are transparency and accuracy. And it's something I figured out 20 or 30 years ago. If you got two different reports about the same events, they should look like each other, or you should be able to explain the differences. And also, are those high rates that the Lund report reported, are those going to impact the goals of the cost growth target containment? That's all.
Great. Thank you so much for your questions and input, David. We will take them into consideration and get back to you. Our next public speaker is Colleen Ruland.
Hi, I'm Colleen Ruland, the Director of the Oregon Pediatric Improvement Partnership. The purpose of my comment is to emphasize how an explicit and priority focus on children who experience health complexity must be a centerpiece of Oregon's transformative goal to eliminate health inequities. We have also submitted a written comment. Health complexity is a concept that combines and then quantifies the degree to which children have both medical and/or social complexity. Since 2018, Oregon has led the nation in the development and dissemination of system-level data to understand the challenges faced by publicly insured children. This allows us now to understand the needs of these children and prioritize them. Statewide, 80% of children have health complexity, comprised of either medical and/or social complexity that impacts their health and can have lifelong consequences. Because childhood experiences are a predictor of a child's future adult health and the health of future generations, health equity cannot be addressed and achieved unless childhood health is addressed and prioritized. We continue to see that broad population policies applied across all age spans nearly always lead to an inequitable lack of focus on children and specific strategies required. 6 actionable ways OHA can ensure children are at the center of Oregon's approach to eliminate health inequities include: 1, staff a child health team to ensure appropriate focus and supports within and across OHA. 2, sustain and expand the dissemination of the child health complexity data and support maximal use. 3, provide support for how to use the data in a trauma-informed and strength-based way. 4, examine relevant and meaningful CCO 2.0 requirements specifically for health complex populations. 5, ensure appropriate investments are made to provide access to intensive case care coordination commensurate with the magnitude of need indicated by the data. And lastly, prioritize behavioral health resources and investments to children and their families, given the multi-generational impact lack of services will have on the family and community. Thank you for your time.
Thank you for your comments and work, Colleen. Glad you got the 6th one in there. Okay. Our third and perhaps final, unless anything else comes across the chat, commenter for today is Dan Cushing.
Good
Dan?
morning, Chair Isaacson and members of the board. My name is Dan Cushing, and I'm here today on behalf of Coalition for a Healthy Oregon. Coalition for Healthy Oregon is an association representing 7 of Oregon's coordinated care organizations. My comment today is about Oregon's 1115 Medicaid waiver that is currently in negotiations with CMS. Coalition for a Healthy Oregon is generally supportive of the waiver, including most of the new ideas OHA put forward for this next demonstration period. However, we remain concerned about the provisions related to implementation of House Bill 3353 from 2021 that would divert a portion of CCO's at-risk dollars. We strongly support social determinants of health and health equity goals, and we were strong supporters of that bill. But we believe it would be more effective if these dollars went through Oregon's integrated and coordinated care model instead of adding a new layer to the healthcare delivery system. We expressed these concerns in a letter last fall, as well as in formal public comments to OHA and CMS. I'm told that OHA convened a small meeting of CEOs several weeks back to share its latest proposal for this part of the waiver. At this time, it does not seem that our concerns are being addressed with this new proposal. We would ask that 1, OHA include all CCOs in future conversations about its revised waiver concepts, and 2, that CCO budgets for which they're at risk remain in local community-based model of CCO governance that has been well established. This will ensure greater accountability and participation from CCO's community advisory councils, as well as making sure these investments are interlinked with the medical, dental, and behavioral health systems. Thank you.
Thank you, Dan, and thank you to all our public commenters today. Our next up, we will move, we'll have John Santa and Zenia Junkier are here today as members of the task force on universal healthcare. They'll provide us with an update on the task force work. Zenia is the chair of the vice chair of the task force, and John holds the quality assurance healthcare accountability member seat with the task force. See how many times I could say task force today. The work of the task force is not overseen by the Oregon Health Policy Board, but it is represented in OHA's Oregon Health Reform Roadmap that has been discussed previously at the Health Policy Board's April retreat and in our January meeting. So we really welcome Zenia and John. It's a pleasure to have you here and to hear about the task force's work.
Thanks, Kirsten. I think I'm going to start, and then Zenia will follow. And thank you for the context that you've provided, because I would like to get up out of my OHPB board seat and move to a task force seat. I apologize about no video. I'm not sure what's going on today, but the bandwidth issues are causing some unusual things to happen in my desktop when I turn my video on. So please bear with me. Well, it's a real pleasure to present on this. The task force approached OHPB about helping us to get the word out about our engagement process. And on further discussion, it was thought that it might be good to give you all a sense of where we are with both health equity issues and engagement issues. So let's go to the next slide. First, let me make sure you realize the importance of Senate Bill 770, a bill that had bipartisan support and passed in 2019 and really has created the pathway for the task force's design work. The task force includes legislators, 13 governor appointed members, executive branch members, and a local government appointee. We are very thankful for the staff work that's done by folks from both the Oregon Health Authority and Legislative Policy and Research Office. Next slide. This has been pretty extraordinary for me. My colleagues and the staff I just mentioned have spent, I would guess, we're certainly into the thousands of hours working on this task. And we've had an enormous number of meetings since August of 2020. We're now focused on report and recommendations that will come out September 2022. Next slide. Senate Bill 770 emphasizes that there should be a commitment to equity in our design. And I might say and emphasize that that really begins with some other requirements of Senate Bill 770, especially the clear-cut requirement that our design focus on a single payer, And that focus really creates enormous opportunities when it comes to health equity. It creates enormous opportunities when it comes to the transfer of power and resources. And that's what I want to emphasize in my brief comments today. Next slide. It really starts here. We've made a number of equity-centered design choices. I could spend an hour on each of them. Instead, I'm going to go through them very quickly and make a couple comments about the two that are particularly interesting. The first is, in our design, everyone residing in Oregon would be eligible. The second, there would be no payment at point of service. So cost sharing at the point of service would no longer exist. Healthcare financing, employment would be uncoupled. The benefit design would be the same or close. You know, it's kind of tricky because of Medicare, because of long-term care, but it would be very similar across the entire resident population. The two issues that you might not be familiar with the language on are the next two. Normalizing reimbursement rates across populations. That means that no longer when a provider office sees a patient, would they say, oh my gosh, I'm going to get twice as much for this patient as I would get for the patient I just saw. Reimbursement rates would be the same for every person, and every person would, from a business and financial point of view, have the same impact. Very, very different from our current situation. Much of this is driven by the fact that in a single payer system, administrative savings are really substantial. And the last element I wanted to mention would be that there would be an opportunity to reinvest those administrative savings in behavioral health and access to care. Next slide. Now, as I mentioned, each of these, we could go into a lot of detail. I'm not going to do this. I'm only going to briefly go through each of these so you can see them and read them. But obviously, by going beyond citizenship, we would be able to reach many, many vulnerable folks. Next slide. By not having payment at the point of service, we would make life a lot easier for people at mid and low incomes in terms of the decisions they're making. We discussed how difficult this is earlier in the meeting when Jessica brought up her example. Next slide. We would no longer really be driven by employment policies and processes when it came to covering healthcare. This last box I thought was interesting. Imagine that coverage would be decoupled from family status. What an advance that would be in terms of health equity for children. We just heard about how important children are and how vulnerable children are because we have a model that prioritizes employment. Next slide. That the benefit design would be the same. Imagine the administrative savings. Imagine the time and other aspects of delivering care would be so much clearer and easier. Next slide. Now, this normalization, that's a term that the actuaries use, is particularly powerful. Because, you know, I live on the west side of Portland. I spent the last 40 years watching hospitals and many physicians relocate here because the west side is where, in the suburbs, is where the wealthier patients are who are more likely to be covered by employer-based insurance. And they'll get twice as much for seeing those folks as they would for Medicaid. There's a deeply ingrained discrimination that occurs at multiple levels when basic payment levels are so different, and they've become very different over the last decade. Next slide. And then finally, getting rid of administrative services that really do not bring value to any, in many cases likely hurt, and in many cases are flawed in terms of health equity. The savings from those are significant and could be reapplied in very productive ways. So with that, I'm going to pass this over to Xenia. Xenia has been an incredible vice chair and an incredible lead for the public engagement process. Xenia?
Thanks, John. I appreciate the kind words. Hi, everyone. My name is Xenia Junkieri, she and her pronouns. As mentioned, I am the vice chair of the Task Force on Universal Health Care. Next slide, please. So public engagement. We are deep in our public engagement process. It's really exciting for me as someone who spent probably the better part of the last 10 years trying to advocate for health equity, informed, community-led and driven engagement that really meaningfully engages folks. I feel really honored to be able to be part of this work on the task force. We've been engaged in this really robust community engagement plan grounded in the work envisioned by SB 770. We believe that public input and awareness is critical to ensure that the final design product meets the needs and the unique needs of folks across Oregon. So we have really been spending a lot of time, not only early on in the process, understanding what we mean by public engagement, what values the task force has that we are grounding in, but also how can we engage folks in a way that is the most meaningful given some of the restrictions that we have, including, we want to talk to folks across the state. We know we're in a time now where, people have access, some people have access to Zoom and remote meetings. And so we're just, all of these considerations are central in our decision making. And we really have developed an engagement plan that centers folks most impacted by health inequities. We've not only looked at the data repeatedly, but have listened to individuals and community members who have named why their voices are so incredibly important in the design of this plan, given the ways in which our current medical system and model leaves folks behind. Next slide, please. So gosh, our public engagement plan, I have so much to say, but I'm going to stick to this slide. So we broke out public engagement into kind of three sections. One is around community engagement, one is engagement with employers, and one is engagement with healthcare providers. We worked on 7 demographically specific roundtables. They were kind of small, facilitated groups in which we heard a lot of really, really powerful information that we've then taken back and incorporated into our work. And then we've got the 5 geographically specific community sessions coming up this month. Moving forward in July and August, we've got some more specialty forums that will engage not only employers, but the healthcare providers we see here. Next slide, please. In our first round of community engagement, community listening sessions, we focused on communities, again, most impacted by health inequities, and ended up with these particular demographically and lived experience specific groups. We started out with a large list of, who do we want to have conversations with? And I think, certainly given some financial restrictions and time restrictions, we really tried to ensure that the folks that we spoke to were the communities who we really wanted to and needed to hear from in our plan design based on the current inequities faced by those communities. Next slide, please. So what did we hear? We heard that people wanted comprehensive benefits. I think in the group that I was in and the content that I read from the other groups, I don't think there was anybody that said, we're really interested in continuing a siloed practice of having certain care for certain parts of our body here and over here. So comprehensive benefits, that we really carefully define resident. What does it mean to be a resident? That we cover all people in Oregon, regardless of citizenship status. That the process of enrollment is simple, that there really is no point in which people can't get enrolled, and that folks don't have to find or seek or jump through hoops to try to get enrolled in the plan itself. And then a single evidence-based formulary for prescription drugs. We talked about, folks in a couple of the focus groups talked about really wanting to have access to prescription drugs that could support their needs and not having providers or systems tell them that they couldn't have access to certain medications, et cetera. So really wanting to use that single evidence-based formulary. Next slide, please. We also heard single reimbursement rate to address discrimination against Medicaid enrollees was incredibly important. The next point around ethically and regionally diverse board, folks talked about, what was really powerful and also really heartbreaking is that so many folks talked about the fact that they couldn't even imagine a system or a model that did the things that we were saying that we were going to be able to do. And that included having representation at the highest decision-making level so that the folks making decisions had some sort of connections, lived experience, or otherwise with community members. Members wanted to choose their provider. They wanted to make sure that they weren't just told, hey, here's the provider you need to see. There were a lot of conversations about culturally responsive care and wanting to make sure that their providers were able to provide that. Broadening access to all provider types. Folks talked a lot about naturopathic care, chiropractic care, acupuncture, massage, wanting to make sure that they had access to providers kind of across the spectrum. And then requiring culturally responsive care. I would asterisk this about 10 times that this came up in almost all of the meetings, or at least the notes that I read, and then the meeting that I was in, that folks, again, couldn't really even conceptualize that this would be possible. And we're really clear that regardless of the model that we chose to put forward and the recommendations that we chose to put forward, if they weren't able to access culturally responsive care, they were unsure about how we could actually mitigate some of the health inequities that we see today. Next slide, please. We also heard that flexibility for rural communities and access to closest providers that, at least for those of us in the metro region, we may have, a number of hospitals and clinics within a certain geographic region, and that we needed to be really conscientious about how we were creating a model that would allow folks in rural communities to access providers of their choice and folks who are closest geographically to them. There was a big conversation about investing in public education, health literacy, cultural interventions. I think, again, this point around not only, not using an equity lens, but really from the get-go, building a plan that was built through a framework that included equity and cultural responsivity. And then there are two really important pieces around financing. One, financing should be based on what individuals earn and what their situation allows. We heard this over and over. And then avoiding taxes with greater impacts on moderate to low income families and individuals. We also heard in a number of the sessions. Next slide, please. So what we did with the information is we, our consultant, Laura Media, they are incredible. We, they put together a report, the recommendations based on what they heard. And then what we did internally was we took those recommendations and we said, what is already in alignment with the design elements that we have worked on in our recommendations currently? Where are there opportunities here? Maybe something that we haven't considered or talked about, and then where are there really direct ways that we can implement change based on what we heard in the sessions themselves. So within these kind of three plan design consideration areas, around affordability, folks really wanted to make sure that people were only paying what they could afford. Again, I think there were some ties to this larger kind of conversation about how can community members even conceptualize a plan that will give them all of the things that we are offering that either isn't going to cost them a lot of money or that isn't going to have some sort of hidden cost. The design considerations around means tested contributions for high income enrollees. A number of folks had offered thoughts about how we could ensure that people who had access to more financial resources were able to reallocate some of those resources in ways that maybe folks that didn't have those resources could. And then the revenue structure, folks talked about the fact that a tax is not progressive if it applies to everyone, and that we really needed to structure the taxes to minimize the burden on low income folks. And we heard loud and clear that folks were not interested in a sales tax. So as you can see here, what we're doing is laying out what we heard from the community and then what we did design consideration wise with that information. It was really important for us to lay out how we were going to take the information that we heard and what we were going to do with that. And then systems costs, we heard, avoid increasing taxes. And what we did with that information is we really examined cost drivers and to reduce the overall cost, as well as to pay attention to the other aspects of how we generate revenue for the plan. Next slide, please. All right, so public engagement phase 2. We are in phase 2 now. Next slide, please. We've got some hashtag summer goals here. These are our public engagement goals. You know, we were really intentional about what our goals were. They were, you know, we had a number of conversations, you know, what is the best way for us to create the conditions for meaningful engagement and authentic space for folks to learn, react, and ask questions? And we knew that doing that would require setting certain conditions in that space, as well as being really clear about what our goals are. We wanted to remind folks about who we were as a task force, share our preliminary proposal, you know, through the process, as well as through the engagement in these sessions. We're hoping that we can build some trust in the task force process, recognizing that trust takes a long time to build. And then we wanted to really hear community feedback and input on specific issues, specifically the spaces where we were really looking, you know, we as a task force, I think, you know, feel like we put our best thinking forward, and we know that there is a lot of wisdom out there. So we wanted to be able to hear that and be able to take that in as we're moving our recommendations more towards a finalized set of recommendations. Next slide, please. So, you know, as we were planning these community listening sessions many months ago, you know, we were trying to project what was, you know, possibly going to be happening with, you know, COVID-19 exposure, you know, opening things back up, and, you know, had talked a lot about in-person sessions versus remote sessions. And at this point in time, you know, have gone with the remote sessions. But I say all of that to say that we were really intentional about choosing how we engaged folks based on region. So wanting to really honor the unique needs that folks had in different regions of the state. Next slide, please. And so as you can see here, we have chosen these 6 regions, and we will be hosting listening sessions. You can see the Zoom link here. We are deep in engagement already. I think emails have gone out to thousands of folks to engage in these sessions. We're hoping that we can get representation from each of these regions at the session. Certainly, we're not going to turn anybody away if they come and they are not from one of the regions. But again, it was really important for us to be thoughtful about holding a space and creating a space where folks from the specific regions can come. We know that regions have, you know, their own you know, needs, you know, culturally. You know, I think that there's also, at least I will say, as someone from the Portland metro region, often, you know, a lot of influence from the Portland metro region voices, you know, perhaps, you know, stronger internet access here where we can show up in a lot of spaces. And we want to make sure that we're hearing from folks across the state. It's really important that we create that space to hear from folks, and we're trying to do it as meaningfully as possible. So these are the next. This is it's a phase that we're in right now, and then the phase 2 of our community engagement. Next slide, please. And so the second part of phase 2 are the specialty forums. So in July, we're going to be hosting 6 specialty forums. They will be facilitated by an outside facilitator. We're engaging the healthcare community, business community, and other stakeholders. These forums will have a bit of a different, certainly a different agenda, I think, than the other regional forums, in part because of where we are in our process. We will be able to share information in July that maybe we didn't have in June. So there's an opportunity to get feedback from folks across the state around different aspects of our recommendations. And next slide, please. And here's a little bit of information for folks. We've got our task force webpage. We have our interim status report. You can receive updates about the process and then submit public comment. We, at least, I think in the majority of meetings, have at least 1 or 2 folks who are submitting public comment. I know that the task force members, including myself, really appreciate the opportunities to hear from folks. So we would welcome you or any of the folks that are part of this work or part of the work that you all do to share your thoughts with us. And I think that's it for our presentation. happy to take questions.
Yes, any questions or comments from board members? Bill, go ahead.
Thanks very much. This is a great presentation. Really pleased to see the progress on this important initiative. I know maybe this is premature to ask or expect an answer, but I recognize that one of the challenges in this is financing, particularly not just around potential taxes or structure of taxes for revenue raising within the state, but also how this would integrate Medicare and employer-sponsored insurance, particularly given the ERISA preemption of state regulation of employer-sponsored coverage. Could you comment on what the current thinking is about how to address that, or whether there have been conversations with folks at the federal level, particularly around Medicare?
Maybe I could try to address those. And Bill, you've mentioned multiple important issues, and that is exactly what we've been doing for the last several months. So we have engaged an actuarial firm, Optimus, and their analysis is at least preliminarily complete. The good news is that the design we've chosen overall would save close to $1 billion. The design we've chosen would result in significant administrative savings. There's some debate about how big those administrative savings would be. And those administrative savings are key to sorting out what will the taxes be. One thing I should have mentioned is we've been fortunate to have incredible experts to help us. Bill Shao, for example, has met with the task force multiple times. Dr. Shao, for those of us who have gray hair, used to be Medicare's actuary and has remained very involved in health policy issues around universal health care, and has consulted with multiple organizations, countries, et cetera. And he and other folks have been key. Two outside experts, for example, have helped us to design what we think is a workable approach to ERISA, such that we think we'll be in compliance with the law and won't need a federal waiver from an ERISA point of view, but we'll be very interested if people like you agree when you hear what our ERISA solution is. Medicare is very tricky because Medicare is 100% federal or almost 100% federal. Let me just say that I think what you're going to be hearing is our preference would be that the federal government agree to what is called a super waiver that allows exemption from a number of things, including many Medicare issues. But we think that, that may not happen for a while. We want to be ready for it, though, when it does. And one way to do that is to seriously pursue a state-based single payer plan, which we think would be possible. But it could be tricky, especially around Medicare, and we've devoted a couple of different sessions to that. Doable, but tricky. And obviously, this design will need to be embraced by delivery system folks, because they're going to be key to delivering on these promises and these savings, because succeeding here depends on them significantly reducing their administrative work. So we've gone through all of those issues and would love to engage you and other folks around the specifics. That's exactly the phase we're at. Xenia, any?
No, that was great, John. Thank you.
Great, thank you. We have time for one last question, be from Brenda.
Thanks. Oh my goodness, this presentation was really helpful, and I congratulate the work group, Xenia, you, John, your leadership in what you've presented to us so far. I am struck by the complexity of this conversation that is longstanding. And I know as our state and country have taken attempts toward this goal in the past, we've met with really significant obstacles. So I'm curious from your perspective, and this is a bit of an unfair question, I acknowledge in advance, but what makes this moment in time different? What makes Oregon's readiness different than perhaps it has been in the past? And so, John, I don't know if it's fair to turf it to you or not, but just curious what your current thinking is.
Well, first of all, I want to mention that Bruce Goldberg presented to the Senate Health Committee recently and went over in more detail many of these issues, and it's recorded and available, and urge you watch his presentation because I think he did a very good job of this. Why is this the right moment? Oh gosh. Let me take a little risk and say, for an Oregon Health Policy Board member, if I go back to my seat, you all, every time I read that statement that the Oregon Health Authority is committed to health equity by 2030. This is the way to get there. This is the way to get there. I would challenge anybody else to show me that we can get to true health equity by 2030 in some other way. That a multi-payer approach can get there. So that's why I, in part, think it's the right time, because of the 5 years I've spent on the Oregon Health Policy Board and because of health equity. I think Senate Bill 770 is an accomplishment. And I've been impressed that both Republicans and Democrats legislators have regularly come to our sessions. They know what we're talking about, at least. And I know some of them, and some of them made statements at the Senate Health Committee, were supportive. You know, will the political lineup, you know, help us along? We'll see. But you know, I believe, as I've learned more and more about this, I mean, nobody has spent probably more health policy time trying to figure out how to make the multi-payer system work than I have. Oh my gosh, when you see the hundreds of millions of dollars we're spending on administration, it's in the billions that are just spent on administration. I mean, just the marketing costs, the commissions. I mean, our actuary agreed that hundreds of millions of dollars are being spent on commissions, and to good people who are explaining how all of these different things work. Will we be able to penetrate and, you know, get people? I don't know, we'll see. That's why I'm happy Xenia is around. And that's why these engagement things are so important. I hope that helps.
Great, thank you, John, and Xenia for the presentation and the work it represents. I have one flag that I wanted to put in your ears as we hear about this very impressive community engagement and listening effort, of which there are probably many across OHA, and we have the challenge of many efforts that don't always talk to each other. So I immediately seemed like some of the feedback that you're hearing through these sessions and the type of health plan that people want and need, and its structure in terms of copay or premium and how the costs work, could be immediately informative to the bridge plan work, actually, as that committee is setting up a plan that will exist in 6 months or something, and we'll have to make decisions about how it should be designed. So I would put a plug in that perhaps you could pass along some of the well collected feedback to that space. And then I would like to ask my fellow board members thinking about this update, similar to our past presentations, but when there is a final report with recommendations submitted from this task force in the fall, would we like to put this on our list for educational webinar or in a meeting presentation? I'd like to hear your thoughts about where this can go next vis-a-vis the board.
I'll just jump again. I am curious around how this body of work actually intersects with our board strategic planning process. So there might be an anchor to that mechanism that seems important to stay close to. Yeah.
Great. Any other comments or feedback?
This is Sandy. I really like John's feedback. When we look at health equity and to get there by 2030, I fully agree with him. And so keeping this on the radar and getting some of that information, some of the methodologies that are taking place would be helpful feedback.
Just a quick comment. This is enormous and really scares me because if you just look at sort of what our state is struggling with right now, we have basic operational struggles in how we manage big systems. And I just don't see any way possible that we could get this done. We've got basic things like, the employment department needs to be able to update their software to get unemployment checks out. And so when we're talking about taking on something like this, I don't know.
Yep. Reasonable flag. I keep thinking about that lawnmower with the rocks and choosing our paths. They all have some rocks. So we better keep working at them. Thank you so much to our presenters, and we will move on to our next agenda item, which is the committee membership work group and our member survey. So I'd like to welcome Susan Otter, Director of Office of Health Information Technology and the lead staff on the committee membership work group, here today to revisit the work group's recommendations that were presented at our April retreat for our consideration. And today we'll take time to discuss and consider these recommendations and how they align with the work group's final report that the Oregon Health Policy Board received last fall. So welcome, Susan, and thanks for being with us today.
Sure, thank you so much. So as Kirsten mentioned, I'm Susan Otter, Director of Health IT for OHA, but I'm also serving as lead staff for the committee membership work group. And we're here today to kind of wrap up one of our recommendations around adopting a consistent member survey for the board and its committee slates going forward, and wanted to get your thoughts on whether we should do that or not. So this is sort of our last piece that we wanted to make sure we heard from you, and it's a holdover from the April board meeting. Next slide. So I'm going to do very brief project recap and reorienting folks to what we're talking about with the member survey and how that aligns within the recommendations of the report, and then talk about the recommendations of our work group to continue the survey going forward and get your questions and discussion and decide whether you want to take action. Next slide. So as a reminder, the committee membership work group was established in the fall of 2020, actually, as the board realized and recognized the importance of its committees and the membership that sit on the committees. The board and its committees are, of course, important decision-making and advisory bodies. And the board identified that we needed better representation on our committees and the board that had expertise in equity, diversity, and inclusion, with representation from communities experiencing health inequities, those that can contribute lived experiences from underrepresented communities, and allies willing to take action to break down barriers to achieve health equity. Next slide. So as part of that, the work group was chartered to inform and develop a process to ensure a diverse and equity-focused committee membership, provide guidance on best practices and recommendation for systemic changes to support an equity-focused membership. In January, the work group started with developing provisional guidance for recruitments that were underway. We quickly brought on an external contractor, Ignatius Bow, who's a health equity expert and was the lead consultant. He conducted root cause and gap analyses, environmental scan, and a series of about 30 interviews with external partners, including more than a dozen community partners and some healthcare partners as well. He also interviewed policy board members, OHA leaders and staff to really understand where we are today and where we need to be going around committee membership. One of Ignatius' first observations and conclusions was we can't just put new people into seats. We really need to think about how we operate our committees and how this links to our community engagement efforts. The final report was presented to the board in October with our recommendations, which the board endorsed at that time. Next slide. Since October, we have taken action in several areas and are continuing implementation of those recommendations. We focused initially on getting baseline data across all the board and its committees' current members. We piloted a survey in November and then finalized the survey for baseline data collection, which we reported out extensive data from the baseline survey at the April board meeting, which includes our RealD, SOGI data, so our demographic data, areas of expertise, health equity, lived experience, cross-cultural experience, and things like region and of the state. We identified where we were strong and where we had gaps, and the results of that analysis are included as links for at the end of this presentation. I'll highlight just a couple of things to remind folks what we learned. At that time, we came back in May to recommend that to kind of bring back our recommendation that the board continue the survey ongoing for new members and revisit the data annually. So we'll talk a little bit more about that. Some of the other recommendations that we've been working on implementing are listed on this slide. We've aligned committee recruitment practices. We've brought on new tools, including an updated OEI gap analysis that staff use, looking at the demographic expertise and other areas where we have gaps for committees in order to focus recruitment efforts. We've had staff training on inclusive and accessible virtual meetings, and we've been identifying and supporting a rollout for committee member compensation as part of structural changes. And I know that Health Equity Committee is looking at charter changes, et cetera. So we have recruitment and inclusive practices, structural changes, and then new resources around engaging members, particularly engaging consumer members for recruitment. Next slide. And one more. So in terms of how our survey aligns with the results and recommendations in the report, we always lead with what we heard from our external partners, including our community partners around this work. And so this slide summarizes the response we received from community and other external partners that were really needed to meet our objectives around committee membership. You can see here there are recommendations around authentic community engagement, better information for recruitment and coordination. The third bullet I've highlighted directly relates to our committee member survey, which is collecting and reporting comprehensive, disaggregated, and granular demographic data about committee members and applicants. And the other recommendations here you can see are around retention, system changes, inclusive meetings, accessible meetings, inclusive practices, and supporting staff and committees with training and tools. Next slide. So the input we received from community and our other partners informed the 4 recommendations in the final report, which include engaging community and diverse, underrepresented, and excluded communities. Second is around recruitment and retention of more diverse members. And a sub-recommendation there includes our standardizing our collection and reporting of demographic and sector data across our members and applicants. Third is around inclusive meeting practices, and fourth is around committee work on equity. Next slide. Just a quick reminder what our baseline member survey included and what we found. The full results, of course, are part of the April meeting of the board and are included in the attachments at the end of this slide presentation. Overall, we found we do have significant diversity across the policy board and its committee members, as well as health equity lived and cross-cultural experiences in many cases. We had an 85% response rate to the survey, which was really pretty high, considerably higher than our similar effort we conducted in 2020. We found there are opportunities for increasing diversity that remain, in particular for Hispanic and Latino, Latinx populations are underrepresented across our committees. Nearly 80% of committee members reported some health equity experience, and 67% reported some lived or cross-cultural experience. We found that 32% of existing committee members have experience as an Oregon Health Plan member, and that included members across almost every committee of the board. And then 13% are actual current OHP members and 19% are past members. The survey sections you can see, sorry if you go back in the little box on the right, these are the sections of the survey. So we asked about experience and as well as demographics. Next slide. So the recommendations of the committee member project group is that we continue to use the survey we use for the baseline survey, and we adopt that as our member survey for all new members of the policy board and the board's committees. Staff will use the survey results in our gap analysis to identify where we need to focus our committee recruitment. And then for annually, we will bring the data back to the board at an annual meeting to assess progress. And we'd also offer an annual opportunity for members to update their survey responses. So I'd like to pause here and see what questions folks have and where you're thinking about what you're thinking in terms of the recommendations.
I just want to put a very clear point on it that I think one of the things that we're exploring today is, do we as a board want to formally adopt these recommendations? So welcome questions and comments. John, please.
Well, I support this work and I support the recommendations. Reading it again, of course, made me recall when we looked at the information, I think a month or two ago. You know, I'm happy to see that age is collected, because we found out that over 65 are underrepresented in committees, and I think that's an important issue. And but then, frankly, as I looked at today's materials, you know, children are discriminated against, and I asked myself, are we within the survey being able to collect information on committee members who have had experience advocating or understanding what's going on with children? And I think it's there.
Yeah.
We just may need to, you know, have a child example or something of that sort. trying to figure out how to report the degree to which committee members have had experience around children issues, and all, I think would be really helpful.
Great, and I'll just mention in the section of the report around areas of experience or expertise, we do have experience in different topics, including improving children's health is one, improving older adult health is another. So we do call that out. So that's data that we've collected and we would propose that we continue to collect. Thank you.
Thank you. John, did you have follow-up?
No.
Okay, thank you. Brenda.
Susan, and on behalf of just the incredible amount of work that has gone into this body that has gotten us to this moment today, I feel really grateful for the attention and the level of detail that you and all of the OHA staff and our consultants that have really led us here. So it feels like we're in a bit of this culminating event, by adopting the recommendations that you're preparing for us. So I have one remaining question for you, which is, where do you think we may anticipate stumbling on these recommendations in the future? So we're vigilant with it. We have ideas about where our recruitment is. We've listened to community voice. We know where we're kind of at our current stage. How do you think this might fall apart, that we might anticipate it so we as board members can stay as aware and on top of it as possible?
A great question. First, I want to just clarify that the recommendation we're proposing today is specifically about the member survey ongoing. The board has already endorsed the full recommendations of the report, but I think your question is probably about the full recommendations and where we think we might have barriers or challenges. I think there is a culture shift that we need in our committees to actually listen to the voices of new members, new voices at the table, and engage in our committee work differently. So I think that component around inclusive meeting practices, how do we, often we set the stage with a question for our committees to wrestle with. And we have, folks who are really understand what the topic is and what what the context is, and can be really targeted in their feedback, and other folks that may be bringing lived experiences to that conversation or engage in a different way that we're not often used to. And so I think we're going to be shifting how we listen and how we engage in discussions in the actual business of our committee work. And I think that's an area that I think we'll be learning and probably, needing to evolve and continue as we go. So that's the one that comes to my mind off the top of my head, but I don't know if there were things that you thought, Brenda, that we might need to be particularly thoughtful about.
Yeah, I mean, I really like where you're at, and I think having our committee leadership support our board strategic planning session this last time around, I think was really helpful. We've done that in the past, of course, and just continuing to think about that you're just sitting on the level of inclusion. How would we know that we're actually achieving where we want to go? What are the leading indicators other than committee satisfaction and engagement and retention? Those things seem pretty straightforward, yet the nuance of what you're talking about is not lost on me in terms of the quality of those conversations, and that decisions are informed in the specific voices that we're describing. So I don't know, it's more of a question than not one perhaps that you can answer, but just recognizing that I'm really attentive to it and interested in continuing to sustain an ongoing thread in this lane. Yeah, despite whether or not it becomes or continues to be an OHPB priority, I think when you make these changes systemic and you deeply embed them in organizational life, different things happen. So
thank you.
Great. Any other comments or questions from board members? Okay, then. Is there a motion to adopt the recommendations outlined by the committee membership work group?
Is Brenda so moved?
Second.
Okay, all those in favor? Okay,
Aye.
Aye.
any opposed? Any abstentions? All right. Great, thank you so much. Thank you, Susan.
Thank you.
Okay, we will move to our last agenda item, which is our OHA 1115 waiver renewal update. Before we do that, I do want to make sure that we have Lori with us. We're running a tad ahead of schedule. I think she's making her way in, which is great. So our next agenda item, OHA's waiver team has been engaging in negotiations with Centers for Medicare and Medicaid, CMS, in the past couple of months since the Oregon Health Authority submitted our 1115 waiver renewal. And there's Lori. So Lori Conyer is OHA's Senior Medicaid Policy Advisor, joining us to share updates about those negotiations with CMS and the work of the waiver team. And thanks for being here, Lori.
Thank you, Kirsten. I think it's been a little while since I've presented to the board, so good time for an update. I'm going to walk through slides, and then we have a half an hour, so I think there will be plenty of time at the end for questions. And I can fill you in a little bit more on where we are as of this week. Next slide, please. So just to re-ground you in where we are, it's pretty amazing. We've been working on this over a year now. And we posted a draft of the application in December, received public feedback, made edits, and submitted the formal application in February. Since February, a couple important things have happened. First off, there was federal public comment. So the Center for Medicare and Medicaid Services posts all waivers. There's a requirement for 30 days. And then at that same time, while it was posted, we began discussions with CMS or Center for Medicare and Medicaid Services in earnest. We've been through all of March, all of April, and the first couple of weeks of May. We've been meeting with them at least weekly, some weeks twice a week, and we've provided lots more details around all of our policy initiatives, lots of questions from them. And really what's happening behind the scenes there is that staff, the Medicaid staff, are writing position papers that then float up both to leadership and then across to what they refer to as their federal partners. Those federal partners include the Office of Management and Budget for anything that's financial related, general counsel, and other agencies that they have to get approval for waiver requests from, or at least, so they're negotiating on our behalf in many cases, and then getting back to us. So we really haven't heard much feedback, mostly collecting lots more information so that they could prepare, for discussions with federal partners and leadership. That ended mid-May, and we are starting to hear back from them. We've been told no on nothing. I hate double negatives, but we haven't been told yes on anything either. And so I anticipate we did hear last week. We have another schedule of meetings, so these are a lot more rapid fire questions on different topics that they're getting from either federal partners or leadership. And so the next 6 weeks are going to be pretty intense, and we've been told that. So we do have an extension. They've assured us that it's coming. I haven't seen it yet, that there's an extension of our waiver until the end of September. Next slide. So we still are working under this framework with the overarching goal to advance health equity in Oregon. I do want to say that, we hear over and over that the administration really supports our focus on health-related social needs, and also on our focus on health equity, particularly with our work directly with community. So over there in that blue box on focusing on health equity investments. There's lots of positive feedback around our continuous eligibility that's in that first red box. So, we are hearing we have an aggressive proposal with an even more aggressive timeline. And so that's why there's so much action going on right now. Next slide. So there were some things that have changed. There have been some things that changed from the initial draft to the final application that went in February. We did remove our request for a closed formulary based on lots of public feedback. We also, again, really from strong public feedback and our focus on equity, removed our longstanding EPSDT waiver. What does that mean? It's early periodic screening, diagnosis, and treatment. It's a federal requirement that Medicaid provides all medically necessary services for kids, so anyone under 18 and under. We've had a waiver so that it tied more closely to our prioritized list, and that waiver is going away with the next renewal. We will start implementing EPSDT with our CCOs and our fee-for-service program in this January. It's going to be a big lift for us. We told CMS that it's, we're not going to be perfect at it right away, but we will be providing, kids medically necessary services, and there will be ways to have, if a child has needs that, normally wouldn't be covered, that there's a pathway for that. We had a retroactive eligibility waiver in our waiver that had never been implemented. I believe it was put in there around the time that we were going through expansion. So that's removed, again, at the request of advocates. And then we did have a request around expedited Medicaid enrollment for people who are applying for nutrition assistance. And in talks with the Medicare and Medicaid services, learned that we don't need a waiver for that. So that work, though, we will re-look at that work after we get through the redeterminations, and all our systems can't handle doing both at once. So we'll look at it once we finish the redeterminations from the public health emergency. Next slide. Also, some changes to the final draft of the waiver that was submitted. We had clarification that House Bill 3353 stated that we needed to request that those expenditures count as medical in rates for the purposes of rate setting. So we clarified that in the application. We also, the Oregon Youth Authority had asked that we not have kids stay on full Medicaid coverage while they're in custody, because they provide, kind of have a host of services and providers that they didn't want to switch up. So in conversations with them, what we did, we switched our final draft to say that the kids in custody of the Oregon Youth Authority would be eligible for our SDOH, or our social determinants of health benefit packages, and start be able to have some of that happen 90 days before release, but they would maintain the healthcare through the Youth Authority. We added request around broadband services for transitions related to extreme climate events. We've modified that a little bit since in our conversations with CMS, and we're proposing that they pay for hotspots and some temporary devices. There really isn't going to be a appetite to cover full broadband services. So, but hotspots so that people can access telemedicine, school kids can access school and those sorts of things during an extreme climate emergency seems completely reasonable. We changed the health equity metrics to increase the number so that there's the health plan quality or health equity quality metrics committee would have the opportunity to add an equity metric. And youth with special health care needs, we are creating a separate eligibility category. It's probably a little more detail than you need, but basically for youth that are identified as having special health care needs and are aging out, so they're going to turn 19, there will be a special eligibility population that allows them to receive the social determinants of health services and also the kids benefit up until they're 26. That's important because that includes dental and it also includes the EPSDT. So they can continue to be covered for all their medically necessary services until they're 26. We've had lots of discussions with CMS about this. Next slide. I would say, I'm not going to walk through the federal public comment. I will say that the public comment that we got was very reflective of the same kinds of comments that we received at the state level. So actually felt good about that just because there wasn't something that we missed, in the public comment from our state. Next slide. So here are all the topics that we've discussed at length with CMS. And like I said, staff have been working really hard to write additional position papers, lots more detail about how things will work. So we're talking about the designated state health programs, that's additional federal dollars. This is one of the top priorities of the governor, and I think it's going to be some pretty intense negotiations around this over the next month. We've talked about where it says managed care rates. Some of that is related to the House Bill 3353 expenditures and for CCOs. And then also we have requested that the social determinants of health services be counted as medical services for the purposes of rate setting. Also, so that they're mandatory and will be appealable by members and treated like a full benefit. We've been shaping along with the community investment collaboratives. We've been refining all of our social determinants of health benefit packages. We spent some time talking about what kinds of coverage we are requesting for both those that are members that are justice involved and in the state hospital. Again, lots of discussions around what defines a youth with special health care need? How do we identify them if they're becoming into a new eligibility group? Lots of discussion around our continuous enrollment requests, peer delivered services, and allowing at least those peers that work in substance use prevention to be able to work outside of a treatment plan. I already talked about the EPSDT, and then we did have a meeting on tribal requests. So we have met with the 9 tribes over the last year, and they have a list of specific requests. We have had 1 meeting so far, and I'm sure there will be more. Next slide. A couple little things since our application was submitted. We have submitted and were approved actually already that we will be offering 12 months of postpartum coverage for women on Medicaid. There was a press release about that. We're one of a few states that have started this most recently. There was a request by advocates to open billing codes for clubhouses that treat folks with behavioral health conditions. And that, again, was a direct feedback from public comment that we received. And then I think, I'm not going to focus too much on House Bill 435 and redeterminations. We're trying to tie pieces together. I'll give an example. So for kids, we have this continuous enrollment proposal that a child can be on and stay on Medicaid until their 6th birthday. We want to implement that so that when we go through the redeterminations, the parents redetermine that child, they're eligible, and then they will stay on until their 6th birthday. So we're working, trying to pair up some of those things. We have to do some behind the scenes, systems changes, but from the member perspective, they will be continuously enrolled all the way, from that one redetermination all the way through. So those are the kinds of things that we're thinking about as we're negotiating timing and things like that. I think that might be my last slide. All right. Yeah. So I'm going to open it up for questions. I think I filled in pieces in terms of what we're talking about. So I'm just going to see if anyone has questions.
Great. Brenda, go ahead.
Lori, we are so fortunate to have you. I'm so serious, for the record, your level of detail and knowledge and the attention to the specifics in this body of work is really critical. And I'm grateful, for your role in it. My question for you is actually about the position papers, and it's specifically about whether or not you would find it useful or are currently doing some other communication with other advocacy groups to help those positions have additional eyes and ears on them. If that's either something you've thought of, or if you've got a pathway to think about inclusion at that level, whether that's helpful or not.
Yeah, that's a really good question. So we have restarted meetings with the CCO CEOs because we recognize that, we're having to make decisions on really short order. We get questions sometimes on Monday for a Thursday meeting from CMS, and they're very detailed. And so, and I do have to commend our OHA staff who've been just really working hard on this. But we do want to start to engage. Our team that works on our community investment collaboratives are meeting weekly with the regional health equity coalitions and talking through, as we have questions, talking through with them and checking. So we are working through those two channels. Certainly open to ideas about what to do with some of the papers. Maybe something that we could post. The only, I guess, caution I have is that, we're saying, here's what we think, and then we have to hear back. So it is truly, some moving, the pieces are moving pretty quickly. But I also want to point out that, we're not trying to hide the ball on anything. And so if there are mechanisms to get more information out, happy to hear them. And John, I think you have a question. I see your hand up.
Yeah, I'm confused about retroactive eligibility. We have it now. It's in.
We have it now. We have in the current waiver and the waiver prior allowed us to waive it, but we never did. And I think what happened in talking to Tina Edlund, she and I were trying to remember, and what we think is there was a fear when we were going to take on expansion population that we might need to waive retroactive eligibility, but that never happened. So it's kind of a relic that was never implemented and is in our waiver. So we're taking it out, the waiver of retroactive eligibility, and we're just going to continue business as usual, and we offer retroactive eligibility.
Oh, okay. So it's taken out of the waiver because you don't think it needed to be in there in the first place.
Right. We've not implemented it. So, and I think in the last waiver, we just missed taking it out. And advocates pointed it out. So we said, okay, that's a good idea. We'll take it out.
But retroactive eligibility will continue.
Yes. Yeah, we're just taking out our waiver option. So, we're not asking for a waiver of retroactive eligibility any longer.
Okay.
Yeah, I know it's confusing. I'm sorry about that. Any other questions?
Thanks. Yeah, I just wanted to connect John's question and Lori's answer back to the question that Sandy had when we were talking about hospital presumptive eligibility. And she mentioned, yes, that dates back to the date of eligibility, and will that be continued? So Lori, thank you for the clarification. I think what you've made clear is yes, retroactive eligibility will still be continuing. And we can get back with some communication in writing about this, because I'm not sure Sandy's with us at this point, but I think that's part of the question that she was raising about the contents of the waiver. So thank you, John, for the question, and Lori for the clarification.
Yeah, so hospital presumptive eligibility will continue. Yep.
Thank you for the clarification. And yeah, we should get back to Sandy with that. She had to step away unexpectedly. Great. Any other questions or comments for this incredible body of work?
Well, let me know when you want me to come back. I can keep everyone posted across the summer months. It should get exciting.
Thank you, Lori. It's a ton of work. Really appreciate it. Okay. With that, concludes our agenda items. The next Oregon Health Policy Board meeting will be Tuesday, July 5th, just after the Independence Day holiday on Monday the 4th. And look forward to seeing many, if not all of you then. Take care, everyone.